Welcome to Journal Club, updates in chronic inflammatory demyelinating polyneuropathy, diagnosis, and emerging therapies. In this episode, a deeper look at CIDP disease and diagnosis, Dr. Diana Castro and Dr. Jeffrey Allen discuss diagnosing CIDP with a focus on updates to the current guidelines for optimal treatment and management. Journal Club is developed by Projects and Knowledge powered by Kaplan and is part of a continuing medical education series. This independent CME-CE activity is supported by educational grants from argenx US Incorporated and Sanofi. Information about the faculty and disclosures can be found at journalclubpodcasts.com/CIDP1. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Castro is a board-certified neurologist and neuromuscular physician. She is the founder and director of the Neurology and Neuromuscular Care Center and the Neurology Rare Disease Center in Denton, Texas. Dr. Allen is a professor in the Department of Neurology, University of Minnesota in Minneapolis. I am your host, Candace Hoffman. Dr. Allen will begin our discussion.
Hi, everyone. I'm Jeff Allen from the University of Minnesota. I am so delighted to be here today with Dr. Castro. Diana, thanks for joining me. I always learn so much from you, and I'm looking forward to this discussion on CIDP. So welcome.
Of course, more than happy to be here today.
Yeah, I think what our objective here is to really talk about CIDP. I want to talk a lot about the diagnosis of CIDP, kind of ground that discussion in some of the guidelines that were recently published, and then really talk about some different treatments. I know I'm an adult neurologist, you're a pediatric neurologist, so I think that should add for a nice discussion on a couple of different angles on how to diagnose and treat CIDP.
Exactly.
All right, so let's talk about what CIDP is. If we can think about CIDP, based on the guidelines, presenting a couple of different ways. And we now think about CIDP as having a presentation that is a so-called typical presentation, and then having a variance or variants of that typical presentation, which have somewhat different clinical features. So when you think about typical CIDP, Diana, what comes to mind? How do those patients really present?
So I am actually also seeing adults now. So I have learned a lot from the adult population, but the pediatric population a little different. But let's just, if you ask me for the typical, will be a patient with that usually presents with symmetric proximal and distal weakness, and they will complain about numbness, sometimes tingling. And when we examine them, we may find decreased reflexes or areflexia, lack of completely of reflexes. I will say that I will make a point right there because with pediatric patients, sometimes we do find more times I find reflexes than actually areflexia. And I think the timing is important, right? We have to think about a patient that maybe the patient got Guillain-Barré syndrome, and then after 2 months, the patient continued progressing or is not getting better, or is getting this relapsing and remitting kind of course. So usually after 2 months, but we can obviously have patients that don't have that history of having Guillain-Barré. Sometimes they just present like that. Will you agree with that?
Yeah, absolutely. The time course can be slow and progressive, or about 20% of patients have that more aggressive acute onset GBS-like presentation, but then just keep on progressing afterwards. So when we're talking about the variants of CIDP, these are still patients that, of course, they'll have those core features of numbness or weakness, but present in different ways. Either the location on the body where those symptoms affect people is different, or which modality really predominates is different. So the named variants of CIDP are those that have this distal presentation where it's numbness and weakness, but still distally in the upper and lower limbs. Sometimes that goes by the name of DADS, or distal acquired demyelinating symmetric neuropathy, but it's just distal CIDP. Another named variant is the so-called multifocal CIDP, also goes by the name of Lewis-Sumner syndrome, also goes by the name of MADSAM, but it's still CIDP in that it causes numbness and weakness, but it's patchy. It follows named nerve distributions or sometimes plexus distribution, so it's asymmetric on the body. There's a motor variant where patients get weak but not numb. And then there's a sensory variant where patients get numb and not weak. But importantly, for both those motor and sensory variants, the pattern should still be relatively symmetric in proximal and distal. We see each of these in adults, maybe about 5 to 10% of the whole body of CIDP within each of these individual variants. Diana, do you see a lot of these variants in kids?
Yeah, so I actually have seen the pure motor variant frequently in patients with pediatric presentation. And I have also some teenagers with the multifocal presentation, which made the diagnosis really challenging when you have a kid who has right hand weakness and left foot weakness, which I have cases like that. So it makes it a little bit complicated. So I think that's why, going back to the diagnosis is so important to really try to get, obviously, clinical picture helps you, but you have an array of testing that we can obtain. It can be done and try to help us really get into the diagnosis, which I think many times, will you agree that it's overdiagnosed?
Yeah, we know that diagnosis is tough. And just from a numbers game, we know that prevalence of CIDP about 5 in 100,000 people. We know that about 60% of patients present with the so-called typical pattern, and each of these variants is about 10%. So if you're talking about 10% of a disease that's already pretty rare to start with, these variants can be really tough. So we know that delayed diagnosis is a problem where patients take too long to get diagnosed. But then, as you're saying, we know that overdiagnosis is really, really a problem as well. And it's usually these variants that really trip us up the most on both sides with that.
Yeah, because talking about like in terms of the diagnosis, we do have to think about like the electrophysiological features. I have had referrals of patients with CIDP without an EMG nerve conduction study, right? You should have, if the diagnosis is difficult, you probably have to have a cerebrospinal fluid, CSF, that shows the albumin-cytologic dissociation, MRI showing enhancement. And so all of these things can really, putting it together, can make the diagnosis hopefully a little bit easier. But again, I think it is definitely overdiagnosed.
Yeah, and one of the challenges is that, of course, there's no single test that we can lean upon and say for sure you do have CIDP or you don't have CIDP. We don't have such a diagnostic biomarker in our field. So just as you say, it requires us to kind of identify these symptoms and signs. Nerve conductions are really, really important. And then to fold in these other bits of data, like the spinal fluid and the imaging, response to treatment, put all that together in order to arrive at a diagnosis. But it can be really, really tricky. I think maybe some of our discussion today is going to be to try to break down the guideline in order to make it maybe easier to use in clinical practice. So let's talk about that a little bit more. So for those of us that have used the older guidelines, you might remember that the guideline broke CIDP down into 3 categories, each with a different degree of diagnostic certainty. It was CIDP or probable CIDP or possible CIDP. Thing that the new guideline, the 2021 guideline, has done is to make that a little bit simpler in that it made it from 3 categories now down to 2 categories. So now it's just CIDP or possible CIDP, because the difference between possible and probable is really quite trivial.
Mm-hmm.
There's 2 categories now instead of 3. Both of those categories require, first and foremost, those clinical definitions that we talked about. So you have to have either typical CIDP or one of the variants meeting those criteria. You still have to have important electrodiagnostic changes, so some evidence of peripheral nerve demyelination, although that's been simplified a little bit as well. And depending on how certain you are with the electrodiagnostic category, puts you into that CIDP or possible CIDP category. And then that's when you start to fold in these supportive criteria, the spinal fluid, imaging, treatment response. And if you have those, then you can kind of increase your diagnostic confidence so you can move up or down depending on how many different pieces of supportive information that you have.
I think the difference right now, which you just mentioned, the difference that we have from 2010 2010 compared to 2021, it's actually helping us making the diagnosis, electrodiagnostic testing part a little bit, easier. So for the new one, you actually now have only two electrodiagnostic categories, one that is strongly supportive, and then the other one, which is weakly supportive. Like you said, we went from definite, probable, and possible to now two categories, which makes it easier.
Yeah, from a practical standpoint, looking at the guideline and each of the individual electrodiagnostic categories can be a little bit daunting. When you break it down into its kind of simplest terms, essentially all you need is one or two predefined demyelinating change in one or two nerves. So that the overall burden is not terribly high, but each different criteria element can be tough to look at and break down. What I do in my practice is I have the criteria kind of in the EMG lab. And so when I have somebody that's got a slowing in a nerve or a block or a latency prolongation, I have the criteria available that I can kind of quickly reference and look at, which really helps me kind of work through the criteria in real time. And in practice, it's tougher to go back and do the study and then kind of retrofit everything. But having the criteria available in the EMG lab is really helpful to me.
Mm-hmm, mm-hmm.
So let's talk about some
Mm-hmm.
some of those supportive criteria in a little bit more detail. What do you break down that supportive criteria for us? What are different pieces that can help increase or decrease your diagnostic confidence?
Yeah, and I think that that's where again, it's just putting the whole picture together. So CSF is it's extremely important. I mean, again, many of the patients that have had referred with a diagnosis of CIDP that have been treated for a while do not come necessarily with an electrodiagnostic testing that supports the diagnosis. And many times they don't even have CSF, spinal fluid, to support. So I think CSF is helpful in terms of that. If there is that dissociation of in the CSF, will probably tell us that we're going in the right direction. It can also help us ruling out other conditions, right? Like if you're thinking people that may have peripheral and sometimes central involvement in conditions like multiple sclerosis sometimes can be confusing. So I think that that's important. Imaging, to me, in pediatrics, I think this one has been one of the most helpful ones, actually. Nerve biopsy is always helpful in those situations where we have patients that are not responding, that we still have doubts in terms of the diagnosis, and also ruling out other things like sarcoidosis, vasculitis, amyloidosis. So all of these conditions that can present definitely as CIDP. And again, we go back to response to treatment, right? Responding to treatment may be helpful, but it's also something that requires the follow-up, our follow-up, and making sure that we're really using some of the scores and using the physical exam to see if the patient is really improving or we're having a placebo effect, because we do have that one often.
Yeah, all of these things can be helpful, but I'm gonna play devil's advocate here for a little bit, if that's okay. We talked a little bit about misdiagnosis and the frequency of misdiagnosis, and part of the challenge with misdiagnosis is when we put too much weight on any one of these individual components. All of these categories are considered to be supportive, for a reason, and none should be diagnostic of CIDP in isolation. And so we know, for example, that normal spinal fluid levels increase with age, they increase with diabetes. Got a bad back, a lot of arthritis in your back can go up as well. It's not even really well accepted on what a normal CSF cutoff is, especially in older folks.
I'm glad you brought that point, because what I'm seeing with all the older folks is that you're having all of these comorbidities that can change the results of these studies, right?
Yeah, that's exactly right. And for me, if I'm thinking about spinal fluid and when I get that, there's two main scenarios that I like to do it in. First, you got to have clinical symptoms that make sense. If the clinical symptoms don't make sense, then your spinal fluid is just going to be more confusing.
Mm-hmm.
But if they make sense, and then you do your nerve conductions, and the nerve conductions just don't reach that threshold to be confident about CIDP, that's the time for me when spinal fluid can add some value, because it really helps you increase that diagnostic confidence or reduce it if the spinal fluid is completely normal. The other scenario where spinal fluid is really helpful is when there's other things on the table. So you think maybe, this is sarcoid, this is lymph
Mhm.
infiltration, this is some other infectious or infiltrative disease. Looking at the white cell count is really important as well. Same with imaging. Imaging is really dependent on your center. Response to treatment, super important to make that as objective as possible. We know that a lot of people feel better. A lot of people want to feel better. We're
Mhm.
physicians. We want people to feel better. We start them on treatment, but are they actually better? Sometimes it's easy to tell. Sometimes it's hard to tell. But we know that, just basing that on subjective experiences can get us into trouble. So if we're using response to treatment as a diagnostic tool, it's really important to objectify that as best we can. These guidelines, I think they've done some things that are really, really good. The way I usually approach them is that you can really get lost in some of the details of the guidelines, but
Mhm.
the high level important things I think to walk away from are, the core is that it's got to have a clinical presentation that makes sense, and there's some flexibility to do that. Most patients are going to have those typical clinical features. Some will have the variants. The electrical diagnosis is really important, but it's really just one or two nerves that have a pre-specified change. Let's shift our discussion a little bit and talk a little bit more about treating CIDP. Do you want to walk through kind of what a typical treatment paradigm might be? Say you've got somebody that's newly diagnosed, clearly meets the diagnostic criteria, and now you're thinking about where to start from an induction standpoint.
Well, I'm gonna have to make a comment right there because we know the proven effective, like the therapies that have been effective are proven to really help these patients are steroids, IVIG, plasma exchange, right? In my practice, I actually try to avoid steroids because the problem with imagine you have a teenager, right? In the middle of his teens, and you're putting them on steroids, guess what? They're gonna gain weight. They're gonna get acne, they're gonna get hair, hirsutism. So I just think that it's a challenging situation when it comes to young people. It's also challenging if you have older people with hypertension and diabetes, right? So I think that that's why my practice is moving towards using IVIG more often, because it's, I mean, in general the coverage is it's good. The insurance, if you present the case and you really have proof that this is CIDP, they will cover the treatment. And now with the other option of having subcutaneous IG, we can actually start some of those patients that sometimes have a hard time getting an IV, and access is complicated. Sub-Q has made a big change in my practice. In general, what I do is start patients on IVIG. I try to keep them on mainly giving a loading dose, and then after that, keep them on IVIG as 1 gram per kilogram every 3 weeks. And then I tell them I'm going to treat you for a certain time, right? We're going to do at least 3-6 months of therapy, see where you are, and see if we can start coming off of the therapy at some point to see where are we going or what will be the next step.
Yeah, my treatment protocol is very similar, evidence-based, IVIG, steroids, plasma exchange, but for all the logistical reasons, typically start with IVIG. Let me ask you, when you start IVIG, how long do you wait until you say this is working or this doesn't work?
I give it 6 months, and that is my practice. I don't know if other physicians. I remember we have had this discussion before. What's your timing?
Usually 3 months, sometimes 6 months if I'm not sure. Then if
Mhm.
I'm not sure and I do IVIG first, and then my next move is to go to the other proven effective therapy, which is usually steroids. If I am sure that there's been an improvement, then that's my practice is similar with yours. Then that's when these discussions about, should we continue IVIG or should we think about something like subcutaneous IG, which has certain, benefits from an autonomy standpoint for long-term maintenance therapy. And so maintenance therapy for me, it's often either IVIG or subcutaneous IG, looking for how often or how much benefit you can get and how well it's tolerated.
I get a question from other physicians sometimes asking me, how do I wean off the IVIG, or can I start getting the patient off IVIG? And I don't think there is, please correct me if I'm wrong, but is there a consensus about really weaning off how to? The way I do it is by time, not by dose. So what I start doing is just, if the patient is really after 6 months responding really well, I will start moving them by, instead of 3 weeks, I'll go to 4 weeks, 5 weeks, and subsequently.
Yeah, I don't think there's any best way to do that, and either lengthening the interval between or reducing the dose, both make sense. My approach is to really ask people, what do you want to do? What is better for their own lifestyle? If they think, they don't mind an infusion every 3 or 4 weeks, but would like a shorter infusion, I think that's fine. We'll do it that way. If they would prefer less frequent infusions, we can do it that way. The half-life of IgG is between 21 and 28 days. So I think it probably makes sense to, once you get beyond 4 weeks, to start lowering doses. But I think either way is a good approach. And ultimately, whatever is best for an individual person is probably going to work out best. So I usually let them drive that. And then I'll typically do that maybe once a year, and for patients that show dependency on immunoglobulin. Then I think we only have a couple of minutes left, but there's one important topic that I want to touch upon before we have to leave. And it's something we talked a little bit about earlier, but that's about kind of how do we follow people with disease? Say we start them on a treatment, and then we have to show that the treatment is working, people are getting better, or somebody's on a treatment and say we stop it. How do we show that they're getting worse? Really, ways to follow people. And I think we're going to maybe have some different thoughts on this, thinking about kids and adults. But when we're assessing treatment responses, what are tools that you look at to say, this drug is really working, somebody's getting better? How do you think about that in the people you take care of?
I mean, obviously in pediatric, it's very important as much as you can get with the physical examination. Most of the patients are a little bit on the older side, so they can follow commands. You can do a good motor testing of the upper and lower extremities, get your sensory testing, I think is important too. And now I try in my practice to start using some of the disability measurements, disability scores, like the iRods and the INCAT, to be able to get an idea of where are we going in terms of response. We are using myometry or grip strength as well in clinic. So I think when it's an older pediatric patient, it's almost like, I would say probably after 12 years of age, 10 years of age, we're trying to use almost like the adult, what we use in the adult population.
Yeah, I think my focus is like yours, is to, examinations are really, really important. Of course, the subjective experience of that patient is really important as well. But especially when we're trying to decide if our treatments are working or if there's a relapse, I try to get some type of more objective, quantifiable assessment for everybody. And the big buckets of things that I try to assess are, some sort of metric that looks at disability and some sort of metric that looks at strength impairment. So for disability, you can use something like an INCAT disability score, which is a 10-point score. We know the change of 1 on the score is clinically meaningful. An iRods disability scale, which is a 24-item questionnaire that goes over day-to-day tasks, and it can be really, really helpful. We know that a 4-point change on that is a meaningful change. From a strength impairment, you can do your RMRC scores. Like you, I really like handheld grip strength. It's super easy to do, gives you immediately available quantifiable result that we know is a good reflection of overall strength in somebody with CIDP, not just hand strength. So I really love doing that on every patient. Sometimes other things like gait assessments as well. But
Yeah. Yeah, yeah. Even what I have been using also, we use 6-minute walk for fatigue, because I do have some patients that fatigue it's a big issue as well as part of the condition, due to weakness, due to immobility and other things. So I start using that. The iRods, I think that's something that needs to be also updated because if you look at the questions, some of them, like, can you read a newspaper? Most of us don't read a newspaper anymore. We actually use the computer, your laptop, your cell phone. So I think that, yes, I agree. A physical exam, obviously you get what the parents are telling you, in my case, where the parents are seeing that is extremely, extremely helpful, because they can tell you, now he's walking around this store, where like we can go to this store, supermarket, and he can make the whole trip without complaining about tiredness or weakness, things like that are very little, but in pediatric are important. And then again, using one of those, of the measure of disability and the handheld, super easy to use, takes 2 seconds doing it, and you can get good information.
Yeah, I think that the place that I'm going is it's maybe less important on the specific tool you use, but more important that you just use something that's really important for that individual person and gives you a meaningful result that's kind of quantifiable. Diana, I've really enjoyed this conversation with you as always. I think we covered a lot of ground here with CIDP diagnosis, some important highlights of the guidelines, and some really interesting treatment and treatment considerations to think about. So thanks so much for the conversation.
No, of course, always happy to. I think we have to keep having these conversations and make it available for people, other physicians, to make the diagnosis hopefully easier to reach.
Well said. Thank you.
Remember to receive your credit and evaluate this program. Please visit journalclubpodcast.com/CIDP1. Thank you for joining us today.